called, and I was afraid it was an emergency, and it turned out to be an emergency. So that's taken care of. So I'm going to start this chapter all over again. There was a portion of it that was in the end of the last lecture. So let's go ahead and get started. Whoops. Okay, this chapter. Oh, wait a minute. This chapter is about sexual and gender disorders, and one of the things we're going to talk about is how this is very much controlled by your culture and by potentially, religious strictures, taboos that exist, and you think that, well, and they've existed for an extended length of time. The strange thing is that nobody studied sex until the middle of the 1900s, middle of the 20th century. Of course, I was alive then, and as it turns out, I lived in the state where it occurred. Um, the first study of human sexuality was done at Indiana University, and it was followed by Masters and Johnson out of St. Louis. So strangely enough, when we talk about human sexuality, we're talking about studies that aren't that old. I mean, this is only 50, 70 years ago that all of these took place. And that was the first one. Freud used to talk about it, and people went, "Oh no, we can't talk about that." This is back when people were dressed like they dressed in tents. You couldn't see their feet, you couldn't see their hands, you couldn't see their necks. The dresses went right up to their chins because women didn't want to show any skin. As weird as that is. The scientific study of human sexual behavior is a recent endeavor. Researchers have only collected data on the prevalence of different kinds of sexual behavior since the mid 1900s. I'm trying to think of the guy's name. It's fleeing me at this moment. Masters and Johnson did their research in St. Louis. Why can't I think of his name? Since perspectives of sexuality became more open, the DSM system adopted broader views of sexual variations and dysfunctions. We used to talk about fetishes. We still do talk about fetishes to some extent, but now we realize that a lot of these sexual proclivities that people have are not socially unacceptable. And because of that, we don't refer to them as deviations anymore. The only time we really think of these sexual or gender as deviant is if it is distressing to the individual or distressing to the society. And it's a persistent situation like pedophilia. Pedophilia is not accepted anywhere. Incest is not accepted anywhere. But other than that, all kinds of oddities are out there, and you come across new ones every day. The other day, I was reading an article about some singer, and she made a big deal about a sexual position called the Eiffel Tower, and it involves three individuals. You know, you I'd never heard of it before. It's it's not important, I guess. But they're coming up with new ideas every day about human sexuality and sexual response, and that's okay because it's once upon a time. Once upon a time, people thought that sex should only be performed if you were trying to reproduce. Other than that, it was recreational, and of course, the Protestants don't like recreation. But yeah, really weird stuff, and we're going to talk about really weird stuff. Back in history, if you go back to ancient times, we can go back as far as you want. They had different ideas, and we might be shocked by some of those ideas. I'm going to show you that right now. This is the Moche culture. As you can see, the Moche were very skilled artisans. This is a picture from 500 AD, and you can see how amazing it is. The Moche controlled Peru for about 1,000 years. They were there before the Inca. The Inca were actually had didn't control Peru for very long, or the area that Peru is part of. But the Moche had controlled that area. Then somebody else took over, and I don't really remember what that group is. And then the Inca defeated them and took over. And they have some interesting ideas. It's okay to kill your enemies, to slit their throats. And that's what's going on in this piece of pottery. This is the lid to one of those pots, to a pot. They also had interesting ideas of what they should put on their pottery, and this is one of them. This is another pot. And this person is having sexual intercourse with the other person. We're not sure who's the male. If it's a male and a female, probably it's a male and a female. Yeah, she's got breasts. There's her breasts. It's a male and a female. Were these fertility objects? We're not exactly sure. But this is a skeleton. This is a dead person having sex with a living person, and you can tell that this person's alive because they have skin tone, and this guy's pale as a ghost, as it were. And here we have necrophilia, which is having sex with the dead, but in this case, it's the dead person having sex with a living person. And I think they've determined that this is a female, and they're having sex. Now, this is really kind of interesting because, and you can look up the Moche culture, the Moche pottery. This is not the most graphic. There's a lot more graphic pottery out there that exists. It's really kind of interesting. We were down in Peru. I was on a Fulbright trip to Peru, and we were looking at all this pottery in a museum. And I said, what's the symbol for fertility? Because a lot of pottery has to do with reproduction, has to do with the need to produce more children, um, and he said, well, none of this. They didn't have a fertility symbol. I said, they didn't. Most cultures had some kind of a fertility symbol. The Greeks used penises. They had statues of penises that they put on corners. It was really kind of strange. Well, it's strange as far as we're concerned. It wasn't strange as far as they were concerned. Anyway, I said, so what was a fertility symbol? He said they didn't really have one. They just showed people having intercourse. And then he showed us, and this was pottery that was isolated. I was like going into the back room to see the real stuff. You're going into a bookstore and you're looking at all the books. And so where's your books about sex? Where's your pornography? And he takes you back behind the curtain. It was the same kind of a situation. The Moche were very demonstrative, and they believed that of having sex with your ancestors, as weird as that is, the Inca actually mummified their dead, especially dead leaders, and they would carry the mummies wherever they went. And if you go to Machu Picchu, they had niches in their walls where they actually put these mummies. As weird as that may seem, but their idea was that you could have sex with your dead ancestors. And they would sometimes do that with mummies, have sex with the mummies. And theoretically, the mummies responded to their sexual intercourse, as weird as that is. Their culture. And this is an indigenous group out of South America, the Inca. Who knows what anybody else did? One of the problems we have with anthropology, with archaeology, is that somebody from Spain found, something pornographic, or that they considered pornographic, like this. When they found that, of course, what would they do with it? Well, they would smash it and pretend it didn't exist. And that's part of the problem we have with studying ancient cultures, is the fact that if it insulted um, your feelings, then you just pretended it didn't exist because you wouldn't want it to taint the current people with this concept. This could be considered pornographic. Um, it was found, they found all kinds of pottery, and you know, th- this is some of the pottery that they found, and this is some of the pottery that they found. Of course, this was on display at the museum. This and this, but that certainly wasn't, and neither was that. So you can look it up, and this is you can look up Moche pottery if you like, and you can see to the extent that they had this stuff. But that's one of the problems with the whole concept of sex. It's private, of course, except in this case, it's very public because this is a pot that somebody made and somebody else bought in this, it was in a store someplace. Or maybe it was a fertility thing. I don't know. We have no idea because the Spanish destroyed all of the codexes and whatnot. We have no idea. In order to understand sexual dysfunction, it is necessary to understand normal sexual function. The basic response cycle is the same for men and women. It consists of 4 phases: the excitement phase, the plateau phase, the orgasmic phase, and the resolution. And I'm assuming most of you have had sex. And if you have ever had sex, then you understand, excitement, plateau, orgasmic, resolution. You're going, yeah, I understand. Okay, but we're going to go through it anyway, assuming that that maybe you've never put a name to what was going on when you had sex. So let's go ahead and go through it because we're all adults here and we all aren't moche. we, we don't have pots to show us how to have sex. The excitement phase, both men and women, when they are sexually stimulated, will become sexually aroused. This takes place when blood rushes to the genital area of both individuals and vasocongestion takes place. Penile erection and minor lubrication in males, and clitoral swelling and vaginal lubrication in females. This is the excitement phase. The plateau phase, during this phase, sexual arousal is maintained and intensifies. If stimulation continues, the individual will go to the next phase. If stimulation is terminated, sexual tension will gradually decrease until they return to the unaroused state. If stimulation continues while in the plateau stage, the individual will reach the orgasmic phase. This phase only lasts for a few seconds when stimulation reaches maximum intensity. Orgasm involves muscular contractions of the pelvis in both individuals, male and female. Males will enter a point of no return called ejaculatory inevitability, when they can no longer control whether they ejaculate or not. The male will ejaculate semen at this point. Females report a similar response that could be termed orgasmic inevitability. The refractory phase, after the sexual release, both individuals will return to the pre-aroused state. Females have the ability of reaching orgasm again if properly stimulated, but males will go through a refractory period when they are difficult to impossible to arouse. The refractory period may last from minutes to hours, depending on the health of the individual. And that's it. That's how sex works. And if you think about it, and if you've ever had sex, then you'll go, yeah, that's about it. That fits pretty well. Direct stimulation of the clitoris is essential for the attainment. These are myths about sex. Direct stimulation of the clitoris is essential for the attainment of orgasms. Research shows that this is not true. During the plateau stage, the clitoris retraction is inaccessible to direct stimulation. The thrusting movement of the penis into the vaginal area creates proper stimulation for orgasm, despite the fact that the clitoris has retracted. But it's the movement of the penis on the skin of the vaginal area. It's the friction. Too much friction, of course, is painful, but just enough friction will actually stimulate the clitoris. Vaginal orgasms are better than clitoral orgasms. It is impossible to stimulate the vaginal area without stimulating the clitoris. There is only one kind of female orgasm, and that is an orgasm. Simultaneous orgasms represent superior sexual accomplishment. Paying attention to something other than lovemaking can lead to erectile difficulties in males and orgasm failures in women. Orgasms that aren't spontaneous, trying to delay orgasm for your partner, can lead to orgasm failures. Size of penis contributes importantly to female sexual enjoyment. Despite what you may see on pornography sites, there is actually little variation in erect penis size. Research shows that the vaginal wall will accommodate any size penis so that a woman will get similar stimulation no matter the length or girth of the penis. One of the things that you need to understand if you've ever seen any pornography is that there are prosthetics that they put on the males a lot. So all the men look like they've got these massive penises. And the reality may be that they don't. It's more like, should I use that word, dildo? Since the prosthetic is so massive, it's almost like having intercourse with a foreign object, let's say that. Robert is a 57-year-old man who came to sex therapy with his wife because of his inability to get erections. For the past 6 months, Robert has had erectile difficulties. 6 months before, he had his first episode after coming home a little drunk. He began to become obsessed with his difficulty as he failed time after time to get an erection. Lois became very upset and frustrated and accused him of having an affair, or worse, no longer finding her attractive. Robert wondered if his age or perhaps his blood pressure medicine was interfering with his erectile function. Both were so upset over Robert's lack of erection that they hadn't tried to have sex in 2 months. Sexual mores have been changing since the beginning of human existence. Each culture dictates their own mores, and sexual ideas tend to evolve over time. Excuse me. Assuming that there is a universal norm is probably incorrect. For example, when I was in Germany, nudity was fairly common on television. When I was in Japan, the Japanese they're different. It was weird because if you travel around in Japan, the girls that read this pornographic literature, it's really kind of strange. But the odd thing is, you'd think, they would be primed for sex. But the reality is, like 25% of 30-year-old females are still virgins in Japan. And it's because of their sexual mores and because of their interesting, they're different. Their culture is completely different than ours. And this is one of the things that we have to recognize, that each culture is going to be completely different. And you can't, just because, the Navajo do it have these different sexual ideas, doesn't mean that the Hopi have the same ideas, or the Sioux have the same ideas, or the Salish Kootenai. You're not going to see exactly the same thing. And it's the same thing with the United States and Europe. You go to France and it's one thing. You go to England, it's another. You go to Germany, it's another. All of their sexual mores are different from each other. They may be similar, but they're not the same. So if you're interacting with somebody from a different culture, you need to understand that some things that are totally acceptable in your culture are not going to be even thought about in their culture. It's just the way it works. It's just the way it works. Observational studies of Masters and Johnson led to the development of special therapeutic techniques that continue to be used in sex therapy. Many sexual dysfunctions have origins in performance anxiety, preoccupation with producing or performing. The individual may take on a spectator role, critically observing their performance rather than unconsciously participating in lovemaking. Sexual, and this is really kind of interesting. Here I've used the word lovemaking. Is it lovemaking? Does everybody think of it as lovemaking? Is it just sex? Should we use a different term that starts with an F? This is the term that I've used. So let's go with that, I guess. Sexual dysfunctions, disturbances of the sexual response cycle or painful intercourse. Paraphilic disorders are intense urges, fantasies, or behaviors involving unusual targets of sexual arousal. And gender dysphoria is strong and persistent sense of incongruence between one's assigned gender and one's gender identity. In the DSM-5, sexual dysfunction is a disturbance in one's sexual response or sexual pleasure. A broad range of disorders are included, representing all stages of sexual response cycle. Sexual dysfunction requires clinical judgment that the impairment is not a normal variation in response, and considering the age and experience of the person, the adequacy of the sexual stimulation involved, and the level of subjective distress. Lifelong versus acquired. Some dysfunctions may be lifelong since puberty. Others develop after a period of normal sexual function. Generalized versus situational. Generalized sexual dysfunctions occur in many or all circumstances, regardless of sexual stimulation, situations, or partners. Others are limited to particular circumstances or partners. Severity, mild, moderate, or severe, based on the degree of distress caused by the symptoms. 31% of males and 43% of females in the United States will suffer from sexual dysfunction at some time in their lives. The DSM-5 reorganized DSM-4's sexual dysfunctions. Categories are gender specific when possible, and disorders are no longer linked to parts of the sexual response cycle. Emphasis is more strongly placed on the degree of distress caused by the symptoms, and diagnosis requires at least 6 months. Symptoms must cause significant distress for the person, be persistent or recurrent, and not be due to another mental disorder such as depression, medical disorder such as a circulatory problem, or the effect of a substance or medication. Okay. Summary of the DSM-5 sexual dysfunctions: delayed ejaculation, erectile disorder, female orgasmic disorder, female sexual interest, arousal disorder, genitopelvic pain penetration disorder, male hypoactive sexual desire disorder, premature ejaculation. These are all the disorders, and these explain them. And this is how long you've had to have them in order to be diagnosed with a sexual dysfunction. A woman's persistent or recurrent deficiency in desire for sexual activity and in normal sexual fantasies or thoughts causing a significant distress is diagnosed as female sexual interest arousal disorder. It may be generalized to all sexual activities or may be situational, involving only one partner or a specific activity. This new category encompasses women who would be diagnosed in the DSM-4 with hypoactive sexual desire disorder and female sexual arousal disorder. Now, the odd thing is that if we recognize what was going on in the Victorian world, this is Queen Victoria was alive, or she was the queen from the beginning of the 19th century to the end of the 19th century, and that's considered the Victorian era. And during that era, human sexuality was not even thought. You were allowed to think about sex. As weird as that is, how did they ever have so many children? Well, they did. But if they weren't trying to reproduce, then they weren't thinking about sex, or they weren't performing sex. So, strangely enough, women were being raised to not think about sex. So if you thought about sex, you were dirty. Okay, so this female sexual interest arousal disorders is relatively common, especially with individuals who were raised by people with these Victorian ideas. Okay, so this is relatively common, female sexual interest arousal disorder. It is a fairly common issue among women. 1/3 of U.S. females experience low sexual desire. 20% of females report arousal problems. The diagnosis is not given in the absence of significant distress. A person who self-identifies as asexual would not receive the diagnosis. They are asexual. Although it can begin at any time after puberty, deficit sexual desire often develops after a period of relatively normal sexual interest. Condition may involve recurrent inability to attain adequate lubrication, swelling response in sexual excitement, or inability to maintain arousal long enough for completion of sexual activity. Disorder can be accompanied by orgasm disorders and may result in painful intercourse and avoidance of sexual situations. In earlier classifications, this condition was referred to as the pejorative term frigidity. The woman was frigid, meaning cold. This was a very common problem leading from the beginning of the 20th century right up to the 1950s and 1960s, to the extent that an individual wrote a book called what everyone needed to know about sex but were afraid to ask, or something like that. That was the book, and this came out in the late 1960s, and it was read by a lot of people. And one of them was that women were afraid to have orgasms, and a lot of women didn't have orgasms. And this is what people talked about: women having orgasms. Was it right? Was it wrong? What was wrong with women who wanted to have orgasms? That was part of the question, as weird as that may seem. So, this whole idea of this being a disorder wasn't. I mean, 1/3 of women have this issue, female desire disorder, female sexual interest desire disorder. Sorry, I didn't get the whole thing. Male hypoactive sexual desire disorder describes a condition of recurrent deficiency in or absence of sexual desire and erotic thoughts or fantasies, persisting at least 6 months and causing significant distress. Some sexual activities, including masturbation, may continue in the absence of desire. Problems with sexual desire may affect a significant proportion of older men, although the persistent lack of desire appears to characterize only a small segment, less than 2% of males aged 16 to 44. I had an uncle. He was married into my family. so he was not of my family. But theoretically, this was his problem. And his wife used to brag about it all the time. That they had, how many kids? 4 kids. They had 4 kids. And she used to brag about it all the time. My mom had 6 kids. And she certainly didn't brag about my dad not having hypoactive sexual desire disorder. I doubt that he did. I'm guessing he didn't. That was 6 kids. But then again, Uncle Jack was supposed theoretically had hypoactive sexual desire disorder, but he had 4 kids. Erectile disorder is the persistent or recurrent difficulty attaining an adequate erection for sexual activity or maintaining the erection until the activity is completed. Some are unable to obtain any erection from the onset of the sexual event, while others may attain an initial erection but lose tumescence, which is stiffness, before penetration or during thrusting. Erectile problems may be generalized or specific. Affected men may experience anxiety about sexual performance and fear of failure. Depression and substance disorders may co-occur. National Representative Survey data suggests that 10% of males report erectile problems. Age is a significant factor, with the incidence rising from about 5% at age 40 to 15% by age 70. In earlier classifications, the condition was referred to by the pejorative term impotence. Sexual desire seems to be the function of several hormones in the body. High levels of prolactin, low levels of testosterone, or a low or high level of estrogen can cause a low sex drive. Long-term physical illness can lower sex drive. Pain medications can lower sex drive. Select psychotropic drugs can lower sex drive. Cocaine, marijuana, amphetamines, and heroin all lower the sex drive. Alcohol at first will lower inhibitions, making sexual intercourse more likely. High levels make it unlikely. Anxiety or anger can reduce sexual desire in both men and women. Cognitive therapists have noted that people with disorders of the desire phase may have fears of memories that lead to the dysfunction, such as believing that sex is immoral or dangerous. Depressed individuals tend to have a reduced sex drive. Compulsives often find contact with another person's bodily fluids and odors highly unpleasant. Women may experience normal sexual desire and excitement phases, but an absence or delay of orgasm, either in specific sexual circumstances, situational type, or in an all sexual activities, generalized type, persisting at least 6 months and causing significant distress or interpersonal problems. Most cases are lifelong rather than acquired. In situational cases, females may be able to reach orgasm during solitary masturbation, but not with a partner. Inhibited orgasm is a relatively common problem among females. About 10 to 41% of women report orgasm difficulties, and about 10% do not have orgasms during their lifetime. And this is what the author was talking about. I wish I could remember his name. He was real famous because he wrote this book and started laughing at people because they thought it was normal not to have sex or not to think about sex or not to have orgasms. He was an interesting fellow. Delayed ejaculation is the inability to reach orgasm or delay in reaching orgasm following a normal phase of sexual excitement. The absence or delay of ejaculation is recurrent or persistent and results in marked distress. Delayed ejaculation is not due to an inadequate sexual stimulation, a medical condition, or the effects of a substance. Age is a diagnostic consideration since, as males age, they tend to require longer periods of stimulation before reaching orgasm. Most cases appear to be situational, such as inhibited orgasm during intercourse, but occurring in masturbation or oral sex. About 10% of males report occasional problems. However, less than 1% report problems persisting more than 6 months, making delayed ejaculation the least common male sexual complaint. It's really kind of weird because an old girlfriend of mine called me. She knew I was a psychologist. I was studying psychology when we dated. She called me. She was getting married to this guy, and he had this problem, delayed ejaculation. And she asked me what to do. Well, I don't know. There's no real answer to this. Um, and I asked her, well, have you tried all kinds of stimulation? I'm sure I used some other terms. Anyway, everything she tried didn't work. And what had happened was this guy was a long distance truck driver. And while he was, one of the ways he stayed awake was by masturbating. And because he was, trying to stay awake for an extended length of time, he would masturbate for 2 or 3 hours without ejaculating, and this became a habit with him. And because of that, he had problems with ejaculation. Um, I know it sounds weird. Most of these things sound weird because we have to talk about sex. And she was an old girlfriend of mine. Of course, at the time I was married, I am still married. What am I talking about? I'm still married to the lady I was married to at the time. So it was really kind of an odd situation. Her calling me and asking for advice. And that was the last time she called me. Premature ejaculation is where orgasm and ejaculation occur with minimal sexual stimulation, within approximately 1 minute of vaginal penetration or before the person wishes it, in the case of the non vaginal sexual activities. Pattern must be recurrent, persistent, and associated with significant distress. Most can inhibit orgasm during masturbation longer than during intercourse. About 27% of males indicated problems with early ejaculation in a representative national sample. However, only 1 to 3% would meet the duration requirements. Ejaculation in less than 1 minute, persistent for at least 6 months, or the DSM diagnosis. Most erectile disorders occurs because of ailments of diseases of older males. Most men with erectile disorder are older than 50 years old. 5 to 9% of men older than 40 years of age have erectile disorder. 15% of men over 60 years of age have erectile dysfunction. However, half the men experiencing erectile dysfunction have erectile function at least some of the time. 90% of all men suffering from severe depression have erectile dysfunction. Since erections are functions of the circulatory system, any damage to circulation will cause erectile dysfunction. Heart disease, clogging of the arteries, damage to the nervous system due to diabetes, spinal cord injuries, multiple sclerosis, kidney failure, treatment with kidney dialysis, alcohol, cigarette smoking, all of these things. Cigarettes are vasoconstrictors, so they cut down the amount of blood going anywhere in your body. And because of that, if you're a long-term smoker, you potentially, if you're a male, you have circulatory problems that cause erectile dysfunction. For deficient orgasm, sensate focus may be combined with education about sexual anatomy and masturbation training. Various methods of systematic desensitization are successful in treatment. For premature ejaculation, the squeeze technique and pharmacological interventions, antipsychotic, antidepressant, and topical anesthetics have been used. The squeeze technique is where, as soon as the man gets an erection, you squeeze the shaft of the penis, and that keeps him from having premature ejaculation. And that's one of the reasons why men have prolonged masturbation as compared to intercourse, because there is some degree of, depending on the male, of course, and this whatever stimulation he's seeking, squeezing has something to do with his masturbation technique, or it may have something to do with his masturbation technique. Genitopelvic pain penetration disorder involves pain or anticipation of pain during intercourse. This DSM-5 disorder replaces two disorders in the DSM-4: dyspareunia, painful intercourse, and vaginismus. Pain occurs during intercourse or persists afterwards, not caused by lack of lubrication, general medical condition, effects of a substance, or another mental disorder. Involuntary contraction of the perineal muscles surrounding the outer vagina in response to attempts to penetrate the vagina is sometimes involved. Normal sexual responses are usually not impaired unless penetration is attempted or anticipated. Specifiers do not include generalized versus situational. It is assumed that the dysfunction occurs in each sexual situation. Causes largely unknown. Women may not seek treatment until after problems, for example, conception issues, occurs, but genitopelvic pain complaints tend to peak in early adulthood and near menopause. Trauma, such as rape or sexual assault, can be causal. Additional causes may be painful childbirth, inadequate lubrication, and abrasion by pubic hair. Systematic desensitization can be used effectively: relaxation, sensate focus, and general counseling. Vaginismus can be effectively treated by combination of relaxation training and Kegel exercises. That's where you tighten up the between your anus and your genital area. That is an area called the peritoneum, and there are muscles down there. And Kegel exercises is where you tighten those muscles and relax them. Kegel exercises. Success rates reported for these interventions range from 83% to 100% at 1 year follow-up. Substance medication-induced sexual dysfunction occurs when there is a significant dysfunction in sexual function that results from intoxication, withdrawal, or exposure to a medication or other substance capable of producing the symptoms. Other specified sexual dysfunction is available as a category to include dysfunctions that do not meet any other disorder's criteria. For example, sexual aversion disorder, a former DSM-4 category, was discontinued due to its rarity. There are a variety of effective psychotherapies. Behavioral and cognitive behavioral approaches produce solid outcomes. There is a clear and concerning trend toward medicalization of the sexual dysfunctions. The exclusive push to market and prescribe very profitable new medications that provide temporary symptom relief will indirectly hinder the development and use of effective psychotherapies. Paraphilic disorders are disorders in which the disturbance concerns the focus or target of sexual desire. Diagnostic criteria for paraphilic disorders describe intense and recurrent sexual fantasies, sexual urges, or sexual behaviors involving objects, children, non-consenting persons, or suffering and humiliation. The fantasies or stimuli may be necessary to become sexually aroused, or their use may be episodic. Paraphilic disorders involving children or non-consenting persons are criminal offenses in addition to mental disorders. Okay. All of the paraphilic disorders are much more common among men than women. The prevalence of paraphilic disorders in the population is not well documented. They are believed to be underdiagnosed. Approximately 50% of those seen clinically are married. The defining pattern of exhibitionistic disorder is the recurrent fantasy, urge, or behavior of exposing one's genitals to an unsuspecting stranger. These fantasies, urges, or actions are experienced as sexually arousing and persist over a period of at least 6 months. Specifiers can be issued or can be used to indicate whether the target was prepubertal children, physically mature individuals, or both. Additional DSM 5 specifiers in a controlled environment, opportunities to expose are limited, and in full remission, symptom free, or 5 or more years. Exhibitionistic disorder is one of the most common sexual offenses reported to the police in the United States. Onset is usually before age 18 and may decrease in incidence as one ages. Incidence is not known, but unlikely to be higher than 2 to 4% of the male population. The individual is frequently introverted and quietly appropriate in ordinary social situations and relationships. Exhibitionistic disorder may be associated with a significant impairment. In a study of 25 males with the disorder, over 90% had comorbid conditions including depression, substance abuse, and personality disorders. In fetishistic disorders, sexual interest becomes focused on non-living objects. The DSM-5 diagnosis can be specified by object, body parts, non-living objects, or other. Fetishistic disorder is a recurrent, intense, sexually arousing fantasies, urges, or behaviors to use objects in sexual contexts. Most commonly, the fetish object becomes a required or strongly preferred aspect of sexual functioning. In its absence, males may experience erectile difficulties. Paulie is a 32-year-old single male. He admitted being somewhat sexually attracted to women, but he was far more attracted by their panties. Paulie remembered first becoming sexually excited when he was 7 years old and saw a pornographic picture of topless women in their panties. While the focus was supposed to be on their exposed breasts, Paulie focused on their lingerie. His first ejaculation occurred at 13 via masturbation to fantasies of women wearing panties. He masturbated into his older sister's panties and would steal the panties of her friends and other women who he met socially. He would go to parties and find an excuse to wander into bedrooms where he would rifle through the drawers until he found the occupant's underwear drawer. He would masturbate into the panties and then put them in plastic bags. He preferred panties washed in Tide and would find excuses to visit women who used this type of detergent. Okay. Freudistic disorder is an intense sexual arousal from touching or rubbing against a non-consenting person, persisting for at least 6 months. Diagnosis can be made if the individual has committed the act or if the urges and fantasies cause distress or impairment. Freudistic disorder usually begins in adolescence and peaks between ages 15 and 25 before becoming less frequent. Freudistic acts such as inappropriate touching occurs in almost 1/3 of the male population, but the incidence of the disorder is assumed to be much lower than that, perhaps below 10%. Okay, Freudism is fairly common in Japan. The Japanese live very close to each other, and their subways are packed. You're right up next to each other. So rubbing against people is fairly common. And this is not, this is fairly common among the male population in Japan. And, you know, it's part of, strangely, it's part of their pornography. It gets really, I'm going to say weird, but the reality is that they have their own way of looking at things, and people in the United States have a different way of looking at things. So Freudistic disorder is fairly common in Japan. And what will happen is women who are not in school will dress like a schoolgirl. And then they'll go on to they'll go on to the subway and rub up against men. and acting like they're 12 or 13 years old. Really odd stuff. Well, only to us. To them, it's not that uncommon. Anyway, Freudianistic disorder. Pedophilic disorder involves intense sexual arousal to prepubescent children, which persists at least 6 months. Diagnosis requires that the person has either acted on these urges or is distressed or impaired by the urges or fantasies. The person must be at least 16 years of age and must be 5 years or more older than the child, generally 13 or younger. Subtypes: exclusive sexual attraction limited to children, non-exclusive sexual attraction has included adults, limited to incest, you only want to molest your relatives, victim category: sexually attracted to males, sexually attracted to females, sexually attracted to both males and females. Diagnosis is complicated by the fact that the behavior is criminal, and mandatory reporting laws require, with few exceptions, notification of legal authorities. The course tends to be more chronic, and the relapse rate appears to be higher in those who are attracted to males. Male sex offenders tend to have lower IQ scores than non-offenders. Among sex offenders, those who sexually abuse children have lower scores than offenders of adults. The incidence of pedophilic disorder is estimated at 3% to 5%. I don't know why I put Samuel L. Jackson's picture here. He's certainly not a pedophile. 3% to 5% of the male population, with the female incidence at only a fraction of that. Actual incidence is unknown. For reasons that are unclear, unsubstantiated cases of sexual abuse appear to have declined by over 50% since 1990. Okay, these are IQ scores. Sexual offenders, as you can see, are not quite as bright. And you can see that sexual offenders against children have a much lower IQ. Those with sexual masochism disorder obtain intense sexual arousal through fantasies, urges, or behaviors involving the act of being bound, beaten, humiliated, or otherwise forced to suffer. They want themselves to suffer. Masochistic fantasies must have persisted for 6 months and must cause distress or interpersonal problems. It tends to be chronic, and activities may remain mild or increase in intensity and dangerousness. One masochistic act, hypoxophilia, involves oxygen-depriving activities such as choking, hanging, or suffocating. Prevalence estimates: about 2% of males and 1% of females reported in Australia. Incidence of the disorder is unknown. More common among higher socioeconomic levels, and many are highly educated and successful at work. We found this when I was in the service. We discovered a pilot had been doing this. He would stand on. They're strangling themselves, and this is what they're doing. They're strangling themselves, and after they ejaculate, they would stop strangling themselves. Well, this one guy, he would get into a locker, and he would stand on books, and he would hang himself. He had a rope hanging from the hook, and he would press against it while he was masturbating. And one day the book slipped, and he hung himself and killed himself. It was weird trying to get him out of the locker. That's hypoxophilia. They enjoy being strangled. There was a movie with hypoxophilia in it. What was that movie? It was about Japan. It had Sean Connery in it and Wesley Snipes. Really, really good movie. Anyway, this was part of hypoxophilia was part of the sexual fetish that they were dealing with at a very important business. Sexual sadism disorder involves intense sexual arousal and fantasies about causing physical or psychological suffering. These urges or acts produce intense sexual arousal and have persisted for at least 6 months. For diagnosis, the act has been committed on a non consenting person, or the sadist is distressed and impaired by the urges. Sexual sadism disorder tends to be chronic. Activities may remain mild or increase in intensity and dangerousness. With severe, especially involving those with antisocial personality disorder, victims may be seriously injured or killed. Prevalence is unknown, but less than 10% of the civilly committed sex offenders carry the diagnosis. Transvestic disorder is recurrent, intense, sexually arousing fantasies. Am I not going to tell you about any sadism? No, let's not go into that. Okay. Yeah. So the masochist likes to be hurt, and the sadist likes to hurt people. Transvestic disorder is recurrent, intense, sexually arousing fantasies, urges, or behaviors involving cross-dressing. It must persist for at least 6 months and must be associated with distress or social impairment. Most experience the sexual arousal by imagining that they are females. It's a male-dominated disorder. Females can feel the same thing, but usually they have to dress like males, but also act like males and be taken for a male. Then they get a sexual charge out of it. But it's most often males. In the DSM-4 diagnosis, it only occurred in heterosexual males, not a requirement in the DSM-5. We have seen it in females, but they didn't really, and it doesn't have anything to do with sex. It doesn't have to do with them having sex with anybody. It has to do with them feeling aroused because they're dressed like that. Transvestic disorder may be distinguished from the cross-dressing that may be involved in gender dysphoria disorder, which is not done for purposes of sexual arousal. Transvestic disorder is a rare disorder in males and extremely rare in females. Incidence is unknown. Transvestic disorder can be specified with fetishism or with autogynephilia, arousing at thinking of as oneself as a female. There are couples who the male has transvestic disorder and the wife is okay with it because that's how he gets sexually aroused. So they play this long-term game of this is dressing up like a female is part of his being transvestic is part of his arousal process. Voyeuristic disorder is intense sexual arousal connected to observing an unsuspecting person who is naked, disrobing, or engaged in sexual activities. Diagnosis requires that the person has either acted on or urges, or that the urges cause the person distress or impairment. Signs of voyeurism must persist for at least 6 months. A voyeur typically does not seek sexual contact with the observed person, although a fantasy of such activity may be harbored. Voyeurism usually begins by age 15, tends to have a chronic course, and when severe, may be the exclusive sexual outlet. Prevalence could be as high as 12% in males, with 1/3 of that for females. There are many additional forms of paraphilic conditions with the intense sexual arousal associated with arousal involving unusual sources of attraction in common for all of them. If these are recurrent and persist for 6 months and cause distress or social problems, they may be coded as other specified paraphilic disorders. And we're going to go there right. Oops, sorry. Well, okay. I'm going to go show you the list. I just want to show you the list. This is in Wikipedia, but it's fairly comprehensive. This is an amazing list. Being aroused by people who can't move around, being aroused by people who have amputations, being aroused by mannequins, being aroused when your erogenous zone is in pain, being aroused by when you pretend that you're blind, being aroused by slashed or mutilated women, being aroused by men who have changed, being attracted to men attraction of younger men to older women, raping and then cannibalizing another person, you being an amputee, people will just cut off limbs or fingers or something. A sexual fetish of people swimming or posing or drowning in water, being sexually aroused by armpits, and on and on and on and on and on. And it's just fairly extensive. And if you want, you can find pornography that deals with all of this stuff. It's all on the internet, as weird as that may seem. Okay, well, let's go back to where we were. You can look at the list for yourself. Fantasies and behaviors often first appear during childhood and become elaborated in adolescence and adulthood. Psychoanalytic perspective results from regression or fixation at earlier states of psychosexual development, reversion to arousal sexual habits from earlier in life, biological speculation, excessive exposure to male hormones, focal brain damage, and chromosomal abnormalities. Evidence is lacking to support any of these possibilities. Conditioning model learned anxiety or inhibition with respect to more conventional heterosexual behavior mixed with positive experiences associated with particular pedophilic sexual expression in childhood. In accordance with a conditioning model, sexual arousal has been established by formerly neutral stimuli through classical conditioning procedures. Social learning model, lack of parental care, physical punishment, and aggressive behavior within the family increased chances of pedophilic development. Often people suffering from paraphilias do not seek treatment unless mandated by legal authorities. They may claim that the therapy is not needed. Lack of motivation for change represents a serious impediment to therapy. It may make deliberate attempts to fool the therapist into believing that the problem has improved when it has not. Recidivism continues to be a serious problem with people with paraphilic disorders. Pharmacological approaches attempt to reduce sexual arousal by giving estrogen-like or progestin-like hormones to males, and this is also known as chemical castration. Behavioral treatments tend to include masturbatory retaining or aversion techniques, a diverse set of cognitive behavioral procedures involving cognitive restructuring, relapse prevention, and empathy training, identification with the victim, have also been employed in individual case studies with some positive results. Gender dysphoria is a strong and persistent cross-gender identification and persistent discomfort with one's assigned sex or the gender role associated with it. Gender dysphoria causes a significant distress or impairment in functioning. Two trajectories are highlighted in the DSM-5. Early onset gender dysphoria starts in childhood. Late onset dysphoria begins at or after puberty. The child expresses the wish to grow the genitals of the other sex. They prefer the stereotypic play, mannerisms, and attire of the other gender. Over time, cross-gender behaviors tend to decline for most children. It tends to be more persistent in girls. Most boys, that's what we're talking about, is a girl being a tomboy. Most boys, 2/3 or more, who do not persist in gender dysphoria identify as gay or homosexual. Girls who do not persist in the disorder identify as lesbian at lower rates. And this is part of the problem when we're talking about gender. Do you want to look like the other gender? Are we talking about sexual orientation? And it's really a very confusing problem for somebody who is working in the field and is trying to deal with this because you need to determine whether they actually want to be the opposite sex, an asexual person of the opposite sex, or whether it's the fact that they are gay or homosexual. In adolescents and adults, and there's tons of different terms, and I don't know them all, and I'm probably making just vast mistakes by even mentioning any of these words. But there are words that mean this, there are words that mean that. I was watching television the other day, and they were talking about actors who were queer identified, and I wasn't exactly sure who they were pointing to. They were actually dealing with men who had effeminate characteristics, and both of the men that were talking are gay. So it was a little confusing. Um, so one of them had written a book about queer identified Hollywood. So the question was, did they ever admit? A lot of individuals in Hollywood got married, despite the fact that they were gay. You know, we have so many terms now that refer to not liking your own gender or wanting to have sex with the same gender. We have so many terms now that it's difficult to identify, and you can get into trouble with people that understand the all the nomenclature because you're misidentifying somebody by using the wrong term. In adolescents and adults, there is frequent, and I don't know the terms. I don't know the nomenclature. I've gone through it before, but some of it there seemed to be a lot of overlap, and I just didn't understand. In adolescents and adults, there is frequent expression of the desire to live as or to become the other sex, including interest in sex change surgery or hormonal treatments. They can be specified as post transition, living as the other gender, and preparing for or having some medical procedure to alter gender in adolescents and adults. Gender dysphoria appears to be quite rare, although little data exists. In clinical settings, males outnumber females by at least 2 or 3. In some countries, for example, Japan and Poland, females may outnumber males. Accurate diagnosis of gender dysphoria is difficult. In the DSM 5, gender dysphoria must be distinguished from simple nonconformity to stereotypic sex roles and must not be based merely on the cultural advantages of being the other sex. Some biological conditions affect fetal sex characteristic development. Congenital adrenal hyperplasia, also adrenogenital syndrome, is a genetic female XX fetus exposed to high levels of androgens during fetal development, and it looks like they develop testicles and a penis, but they don't. They are females. These are females with XX. That's a male who is actually XX. So this is a female who's actually an XX. That's what it is. And these are females that are XX as well. That's not right. Oh, they were exposed to too much male androgens. That's what I've I've got this mixed up with XY syndrome. Okay. Or XO syndrome. Androgen insensitivity syndrome is a genetic male fetus, shows general XY. She's XY. General insensitivity to androgens during fetal development and is born with undeveloped sexual structures. These or other pseudo hermaphroditic conditions or others who are troubled by cross-gender identity are given this specifier, androgen insensitive syndrome. And these are individuals with androgen insensitivity syndrome. And that is their clitoris. Their sexual characteristics aren't pronounced like they normally are. Gender dysphoria develops in early childhood and is usually established by age 3, suggesting that causal factors are located in prenatal or early postnatal development. While androgen and estrogen exposure can affect masculinization and feminization, there is no direct evidence that hormonal exposure causes gender dysphoria. There is no clear hormonal distinctions between those with gender dysphoria and those without it as adults. Sex reassignment surgery appears to be among the only effective treatments for chronic gender dysphoria in adults. It is recommended that the person preparing for sex reassignment first complete 12 months of life experience as the other sex and 6 months on the continuous hormone treatments to be a candidate for surgery. Reviews of outcome literature reveal that most transsexuals are satisfied with the outcome of sex reassignment surgery. That is the end. I apologize. I should have looked through this before. Yeah, sometimes one of the things that I saw while I was working in medicine, I had a neighbor. They had a little baby, and the baby was born without labia on her vagina. She had a labia minora, but not a labia majora. And they wanted to show me for some reason, because I was a medic, I guess. They wanted to show me what was going on. And then it turned out that the wife didn't have labia either. And that was a little interesting. She was able to reproduce, obviously. She was able to reproduce. But she didn't have a labia either. And of course, they had to show me that too, so that was a little strange. Anyway, odd things happen to everybody all the time. So I'll talk to you again next week. Next week, we're tackling 2 chapters again. I think it's 10 and 11.